Good afternoon, everyone. So today we have a guest lecture, Dr. Chamindu Weerasinghe, consultant anesthetist. So we are honored to have you for this today very interesting and important topic you are going to talk to us. So without wasting much time, I cordially invite you to present your lecture. Thank you.
Thank you so much, Niyanti. First and foremost, I would like to thank Dr. Jeeva. I call him Jeeva because as a brother, so I'm sorry. Dr. Jeeva for inviting me for this lecture. On top of that, Nilanti, thank you so much for coordinating everything, doing every heartbeat all the time. Even I'm ghosting you, you put your all the effort to make it a success, right? And I would like to remind Ashan, the former consultant anesthetist who worked here. He initiated the event. Unfortunately, he got immediate transfer. So I would like to thank him as well to arrange this scenario. And on top of that, my former team, anesthetic team, that I trained in during short stay at CESR. So they are conducting a workshop now. So in this hospital, and it's very nice to see juniors taking the responsibility. Wherever, like even they are medical officers, I'm so thankful. I'm so glad to see our doctors put in their maximum effort to make their colleagues more strength in future. So it's a good initiative. So it's well done, and I'm so thankful. And this is whatever we started by myself and Jiva together. We had long chats about doing this, empowering medical officers, giving them the responsibility, giving them the leadership, taking them to the picture that they should deserve in this country. So unfortunately, I'm no longer there. I won't come back, and I don't know. So unfortunately, he's continuing that bit, and I'm always happy to help him whenever he asks my help. So good thing. I think he will do some difference in ability as well, hopefully. And so, without wasting too much time, so I would like to talk about this difficult decision making and management in post-hospital care. So basically, that is what we are lacking in this country. We do things, but we don't have knowledge. We don't have the skills. We don't have the like it's not the responsibility. We don't have that drive to take decisions, right? We all the time pass the ball to someone to take the decisions. Okay, so you to take the decision. Then there's a question. Now we take the correct decisions, right? So you guys always thinking, okay, we have little bit of knowledge from the faculty days. That's what we have. We don't know much. So the decision I'm taking, is it correct or wrong? But be frank with you, I'm working in Bermingham. So it's one of the largest hospital in UK. It's the largest hospital. It's the most busiest hospital as well. So I'm working with a huge variety of doctors coming from different areas of the world. So by knowledge, I still believe Sri Lankans are much better. Believe me, right? Scales wise, they are super Sri Lankans. So only bit is we don't have the confidence of decision making. That's why I thought of rather than giving you too much details. This is a very simple lecture. I know everyone knows about it, but I want to make a conversation. So don't be afraid. Just question me. If you want, you can ask anything. Don't call me sir. Call me by my name, Chamindu. That's fine. I let that my ego long way back when I leave the country. So you are free to ask any question from me. I don't mind, right? So anytime you can stop. You can ask, hey, what are you speaking? Tell me about this. I don't mind. I don't mind the way that you brought it up. I'm ready to bet whatever the ball you are putting to me. Okay, ready? So the ground rules here is a two-way communication. So it's so unfair for me to coming all the way and only myself talking. So 50-50 we will talk, right? You try to talk by yourself. Try to change the system, right? Try to be different. Ask questions why you are taking decisions. Is the correct decision that you are making at this point? So I don't have a lot of time. Just I don't want to take 1 hour either. So it will be a very brief session. 3 case scenarios. All 3 case scenarios I took here are real, managed by myself back Birmingham, right? So then we will discuss about how we take this decision. It's about management. I know you all about management, how to manage patients. So something about very small things. These are not hard, fast things. Very simple, straightforward stuff. On top of that, I'm not a proper speaker. I speak in a different way. So I'm sorry if I make you uncomfortable being different. It's me, right? So first thing is, why do you want to know about post-cardiac arrest management? Number 1. Why do you want to know? Anyone from intensive care? No. Anyone from emergency department? Come. Yeah. Anyone from medicine? Medical, just hands up there. Right. Surgical departments? Surgeons? Obstetricians? Surgeon? Obstetric? Right, that's okay. So, why do you want to know about post-resuscitation care, cardiac arrest management? Because the thing is, you all the time encounter these problems, and you should know it's very important to decide, are we going to escalate up to what level of care? And are we, because the most important thing is not to take the patient back. Most important thing is, am I sending this patient home without a deficit? That is the most important thing. You can take hearts. It's not a big deal. The living example about it, me. I did a lot of errors when I was working here. I was very junior, right? I all the time I fought with my consultants. I took a lot of hearts back. I say, oh yeah, I got my heart, okay. What kind of heart did I do without a brain? Right now I can realize if people who work with me, even in Mataro, where they know about me, I'm so patient conscious, and people say so. And I easily get irritated. That's how they say it. And I was thinking death is not, I was not accepting death. That's my main error, right? I was all the time thinking people should, it's my responsibility to take the patient's life back. They should live, they should live, they should live. But even Buddhist, I never accept death. So it's my fault. So by knowing this, and even taking the heart back, if I didn't manage the patient properly, right? If I didn't send the patient back home, what am I going to achieve that? Right? So what a waste of time. So maturity talks now, right? So I'm not taking other people's examples. I'm taking my examples, my experience, my thoughts, and I'm doing what we call critical evaluation, right? So you can learn from what I'm saying, right? Okay, hopefully. So first bit is a proper lecture thing. Sorry. So first we will understand what's the pathophysiology underlying this cardiac arrest, and then we will try to find out how we do the secondary survey and optimize the life maintaining parameters, and then we will go through the key principles in post cardiac arrest management. So case number 1, 49 years old male who came to emergency department following a cardiac arrest in the community. So he was given CPR by the paramedics, not like in here in UK. The first encounters are paramedics. They go there, they do the CPR. So they put initially it was a VF. They have shocked the patient, put an LMA. It's an eye gel, and the patient was brought to the emergency department. So in this patient, got his heart back immediately after resuscitation, short brief period of time. And you know, at that initial 1 to 2 to 3 hours, it's a very low flow state because there was a huge insult to the heart, right? Heart was stopped, we restarted, right? So if you expect by giving a drug, if you are expecting drug to act very quickly, it won't happen like that. It's a low flow state, remember that. So you need to wait. For example, just after you took the heart, so you check the blood pressure. Blood pressure was 90, sorry, 60. So you can give ephedrine, or you can start on adrenaline infusion, and you are waiting 5-10 minutes, still blood pressure is low. What you are doing? You are increasing it very rapidly, right? But it takes a bit of a time for the drugs to go around the body, go to the tissues, act on the tissues. So because the flow state is a low flow state, right? So you need to understand what's going on with the patient. Okay, so the physiology and the pharmacodynamics are different following the post-cardiac arrest, right? Wait, don't rush, because if you put too much vasoconstrictors, what will happen is at one point, it will shoot up, boom. At that point, patient become more tachycardic, tachyarrhythmia, then you need to manage that bit as well. That's what's happening most of the time. We are anxious and we never expect this kind of changes in the patients, right? Okay, the other thing is, so just after the cardiac arrest, the heart was at a stunned state and now restarted. So the perfusion to the heart is not perfect at that moment, and sometimes there's a huge oxygen depth in the myocardial muscles, so they are slowly building up, right? You can imagine. So you should not strain the heart. Remember about that as well. The other thing is, if you make a more positive pressure, try to ventilate the patient very very hard, try to achieve very high targets at initial rate. Again, the circulation can't stand against what you are doing to the patient. Very invasive. So you need a fair balance. I can't say this is the exact balance for this patient. It's about its individual patient as a different threshold. So don't go by small doses, incremental and small settings. Try to achieve a reasonable targets initially. Always have your targets. Those are not high-fi targets, very small targets. For example, map of even 55, I don't mind, right? Even map of 60, that's fine. If the patient is producing urine more than 0.3 ml per kg, I don't mind at all at initial beat. I'm talking about 1 or 2 hours, right? First few hours. Then gradually when the heart start to work, gradually when you're supporting, you can increase your target. So always aim for your main aim is to maintain your vital organ functions with minimum settings, minimum interactions. The other thing is, so you're maintaining the functions of the patient's body organs at a minimum targets, and if the demand, what will happen if the demand increases? So there will be oxygen debt. So you need to reduce the demand, because everything depends on your demand versus supply, right? So because your supply is at a low state, and top of that, hi Vajra. Oh, I'm amused to see you here. She's my batchmate. So I'm really glad to speak in front of my colleagues. Yeah, that's good. So what I'm saying is, you need to have fair balance, because don't target too much. On top of that, you reduce the demand. How we are going to reduce the demand? If the patient is fatigued, what will happen? The brain shoot up, muscles twitching, more oxygen requirement, more ATP requirement. So patient is gradually deteriorating because the demand is very high, but at the same time you are maintaining very low state. Is it possible? No. So you should always stop the seizures, all the seizures. Top of that, if the patient is severely hypothermic, body tries to get the patient's temperature back. So there's shivering, things going on. So you need to maintain the temperature, right? And other thing is, if the patient is vigorously moving, anxious, so you need to calm down the patient, right? The patients who are not immediately coming up immediately gain the conscious level after the resuscitation, you need to put the patient to sedation. It's a deep sedation. You don't have to paralyze all the cardiac arrest patients. You don't have to, remember. Don't paralyze unnecessarily your patients. If needed, yes, of course, right? You can give a bolus of atracurium, see how he's doing. On top of that, because if you put the patient to paralysis, but the thing is, patient is not adequately sedated, the requirement again increases, right? So you can deeply sedate the patient and support the heart with your inotrope vasoconstrictors, what you are using by that time, right? At the same time, you need to understand whatever you are doing, this is to support the life. But real problem, you need to understand what is going on with this patient, what is the primary pathology. So you need to identify the primary pathology, do the intervention for that primary pathology, because if you are not correcting the cause that lead to the cardiac arrest, maintaining vitals doesn't mean anything. Sometimes I have seen, we have resuscitated the patient very nicely. So there is an ongoing ischemia, but the patient is not taken to cath lab, right? At that point, we are having very strong conversations with our cardiology colleagues. Okay, you need to stent this patient. You need to do that. Otherwise, the patient is going to die. Whatever I'm holding, the numbers doesn't make any sense for me, right? So you need to talk to your colleagues. You need to convince your other disciplinaries And you need to correct the underlying pathology, because remember, the resuscitation process is a multidisciplinary approach. There is no heroes, no single man shows. You need to communicate with your colleagues, and if you're not happy, then you can escalate to your consultants, right? Then the consultant should come and talk, because this is a life. So they need to make the decisions. I'll give an example. There's one patient, he was 21 years old, Muslim gentleman. He got dilated cardiomyopathy. His ejection fraction was 28 3 weeks back. Came to the hospital after a infection, now having an ejection fraction of 10%. And the cardiology consultant called me. He is Sri Lankan as well, so one of my very good friends. It's a consultant, long way back. Like he was in UK for nearly 20 years. So he called me and say, I was a senior age. So he called me and say, Cham, can you please review this patient? I want this patient to IT. Then I came. Ejection fraction of 10%. What are you going to do? Dilated cardiomyopathy on treatment. So there is no transplant plan. So they want to put the patient intubated. The patient saturation is around 90% on NRB of 15 liters, right? Patient had a one cardiac arrest. So the VTRS, they have given the shock, took the patient back. So patient is conscious, speaking, and very nice guy. So they want me to take the patient to ITU. I said, no, I'm not going to take this patient to ITU unless you are going to do some mechanical support. What kind of mechanical support can you do for this patient? So we need a mechanical devices like we can, there are even extracorporeal ECMO therapy, something like that. We need backups, because putting a tube is a very simple task. I can put a tube, I can put it into the ventilator. With the positive pressure, that 10% heart won't stand. Patient will die like boom whenever the tube goes. I explain, no, I won't do that. So then we need to find a center where is the ECMO facility and the mechanical cardiac, even the balloon pump is not going to make difference. Balloon pump will increase just 5 or 10%. If the EF is around 20%, I may consider putting a balloon pump, right? But the thing is, I may ask them to put a balloon pump, but it won't help. 10% globally dilated heart. So that point, we are pushing them. No, talk to the QE, talk to the cardiothoracic team and the advanced cardiac team there. Take the decision. Until that, we are not taking this patient. 21 years, bed is over, but I didn't took the patient. Then somehow, one of the cardiology consultant has called my consultant, and he's calling me and asking, Cham, why you're not taking this patient? I said, if you want, you can take this patient. And what are you going to do? Patient is already in CKD3, stage 3 AKI. Stage 3 AKI. So at one, potassium is increasing in trend, bit asymptotic. At one point, we need to start CRRT. Again, if you start CRRT with low blood pressure, with this 10% of heart, definitely patient is going to clash. At that point, what am I going to do? Right? I'm not going to please any cardiologist or my friends, my colleagues. I'm not going to please them. I'm doing my job, and I'm speaking on behalf of the patient. So, consultant agree with me. I totally agree with you. It's up to you. You take your decisions. I respect you are taking decisions, your decisions. So she allowed me to do what I want. Then they talk to the advanced cardiology team. They accept the patient. We transfer the patient. Then they put the patient to ECMO, right? Then start on CRRT. Understood? So the post-resuscitation care, most important thing is decision making. It's not about what you are doing things. So always you should understand why what's happening. Is there a plan for this patient? If there's no plan, no point of escalating. Am I correct? Simple like that. Okay, in immediate management, always go by ABCD approach, airway. See whether this patient is maintained the airway. If it's a LMA, change it to a definitive airway. Maintain target saturation of 94 to 98, that's fine. Even if the patient is showing COPD, obese gentleman, non-patient with hypoxic background, you can consider even 88 to 92%. So I told you, always target the lowest things at initial because this patient is not going to run a marathon, right? This patient is not going to walk to the toilet. This patient is not going to get out of the bed. You don't have to maintain too much target for these patients. Go by the minimum targets. Then you don't have to go too much drugs for this patient, right? Less intervention, less drugs, then gradually build up based on that background. Make sure your capno is there and make sure the patient is ventilated and having a normal capnia, right? The circulation wise, make sure you take the ECG, 12-lead ECG. If you can do an echo, that's fine. Target the systolic blood pressure more than 100, that's more than enough. I go by map more than 60. Initial bit is, that's fine. But it's individualized. For example, a patient with hypertension, CKD background, I may consider, I love to have map of 70. But if the patient is severely septic and if we need to start on multiple line drops, I may even consider 55 at initial bit till the antibiotic works. And if the patient is not acidotic, if the lactate is not rising that bit, I would like to do that. Targeting of map of 55 and starting on CRRT. Right? I will keep the kidneys bit relaxed at that point. That's how we take the decisions. It's all about quick, balanced decision making. Right? Then another thing is control your temperature. That's very, very important. Temperature management, the post-resuscitation of care mainly depend on, they emphasize on targeted temperature management, TTM. So the target temperature in this slide, this is what we get. I took it from the ERC. It's ERC and UK resource has different principles. European Resuscitation Council is different from the UK Resuscitation Council. They have different targets. So in UK Resuscitation Council, they target normothermia, 37 Celsius. Our practice is to keep the 37 Celsius of body temperature. But initially, we in ERC guidelines, so European Resuscitation Council guidelines, they target relatively bit hypothermia, low temperatures, 32 to 36 Celsius. Right? The reason is they believe keeping the blood pressure temperature low, the metabolic demand is going to be reduced, BMR is less, and the brain activity will be less. It will reduce the demand. Right? But now the UK resource recommendation is to keep the temperature at 37. So if it's a cardiac arrest, so you figure it out this way. Is this patient having a 12-lead ECG? Okay, it has ST elevation. So we need to do a PCI, coronary angiogram or something. That is the gold standard treatment. I don't know how in this one, if we don't have coronary care in the cath lab here, so we can't do that, right? What we can do is, okay, we don't have we can't put a stent, but you need to consider giving altiplase or streptokinase or whatever thrombolytic agents that you're using, or you need to decide, are you going to do an enoxaparin, therapeutic dose, or whatever you are doing here, right? Definitive management. I'm not going to talk about right or wrong about what you are doing here, but I'm giving you the insight about what to do, what you should force as a critical care physician or a critical care person who is managing this patient. Understood? Any questions? No. Right. So they have done a ECG for this gentleman, and they found a widespread ST segment elevation. So he's intubated and ventilated, and he was admitted. They put a stent as well, admitted to intensive care. So then we were managing this patient during the intensive care. So in intensive care, when you are managing this patient, we have few principles. First thing, now patient is resuscitated, done the primary intervention. Now what? Intensive care. Got the point? Right. Okay. At this point, we have time. Patient is not going to die. You need to dig on to the history, find out what's going on with this patient, what kind of background is he coming, right? then you need to systematically analyze this patient by organ, try to find out any faults, anything you can correct on this patient. So without having a proper history and examination, you should not talk to the relatives. Put yourself into their boots and see, because if something happens to your patients, your parents, you think doctors are the gods, especially in this country. They will save my parent, my father or mother. So they have 1,000 hopes. So if you, whatever you're coming out of your mouth matters for the patient. They are human beings. You are dealing with human beings, right? So best thing is to know your patient, then talk to the family. It's very important to talk to the family. So this patient, actual downtime was, even they say the paramedics came to the scenario within 5 to 10 minutes. The downtime is around 20 to 21 minutes. So we are not sure about what's happened to brain. Right? We did a CT before patient go to the cath lab. CT brain was normal. So when we talk to the family, it's a Muslim community. So it's again very difficult. So they want to do everything for this patient. Then we ask, what are the wishes for this patient? So because we have to know what this patient wants to do if he in this kind of situation. Any kind of that kind of a discussion have been made or done with their beloved family. No, they say no, nothing, no. We want full escalation. We want him, everything. You need to do understand everything for this patient. So, but that point, don't give them too much, like don't make them too down, as well as don't give them too much hope either. Talk in a midway and say, okay, hopefully we'll see what will happen, because every day is a new day. We don't know what will happen tomorrow. At the moment, what I can say is patient is on the ventilator. We are paralyzed and ventilating him. So his numbers looks fine, but even though the numbers looks fine, we don't know what kind of insult to the brain, whether he will be a normal individual after this event or not. We can't comment about it, right? Tell like that. So they know, okay, at the moment we are fine, but we don't know about tomorrow. So close the discussion with a pause, right? Okay, then meanwhile, you need to continue your management with your other disciplinaries. Talk to the physicians, talk to the cardiologists, talk to your other specialties, physiotherapist, right? So nutritionist. So get the team on board, manage the patient. Right. Now talk to yourself, how are we doing this year? Because we have a lot of patients, we can't do that. But if you again think, this is a human being, right? They have a right to live. They're paying tax for this government. So the government is paying us money as well. It's our duty to do, because it's a human being, so we need to do optimum care because it's available. The cardiologists are available, physicians are available, nutritionists are available. It's a matter of a phone call. It's a matter of giving a shout to other specialty, other room. Do that. Get their opinion. Try to give maximum at initial bit. You don't know. So how long are you going to do that? Right? So remember, meanwhile, when you're doing everything, prevent secondary organ damage, especially brain, heart, lung, kidney. Out of these 4 organs, the worst organ for me is the kidney. My God, if the kidney shut down is a big trouble. Either you need to start with CRRT, right? I don't care about the heart because you can start on, you have multiple options. So in an ITU, if the blood pressure is low, to start a CRRT, especially in this country, it's very difficult, right? It's really challenging. And top of that, remember, in a post-resuscitation period, there is a syndrome called post-ROSC syndrome. So it is a systemic disease which happens because of the reperfusion injury, right? Heart suddenly stopped, therefore there is ischemia in the particular tissues, and now is starting back. blood is going towards these tissues. They are releasing vasoactive immediate drugs or the chemicals. So they are producing a lot of effects, right? So remember about that. So what you need to do is maintain the optimum ventilation and the hemodynamics for the patient. Remember this word optimum. I'm not saying ideal. These are two different words, optimum and ideal. Sometimes the blood pressure of 90, sorry, systolic of 90 will be okay for particular patient. Sometimes 110 will be fine. Keeping the saturation of 88 is okay for certain group of people like COPD, obese, morbidly obese patients. Yes, you can't touch it because you can't ventilate that. That kind of huge bodies. For example, obese patients. Last time we managed, we intubated a 185 kilograms patient. So it's very common in UK. So we get very big patients. So you can imagine 180 kilograms patient putting a tube, giving a positive pressure to get her breast is like this, my God, the breast, because of the breast, you can't push the lungs out. The carbon dioxide is sky high, but patient is not acidotic. It is around 7.2728, that's fine, it's not dying pH. Right? Always go for realistic targets, for the individual targets. And top of that, do the neuroprotective measures from the time you start your post-resuscitation care. Neuroprotective measures. What is neuroprotective measures? Okay, it's like that to protect the brain, right? First, shut the brain, giving good sedation. If there's seizure activity, stop it. Give anticonvulsant, Keppra, or whatever you are using, sodium valproate, whatever you are using. Then maintain a decent map to maintain the cerebral perfusion pressure, CPP, right? Usually, systolic blood we go by map. Map of more than 65 is much better. And top of that, head raise 45 degree to prevent venous congestion, preventing the back pressures. If there's cerebral edema, treat for that cerebral edema. Maintain your sodium at decent level. If it is a brain issue, you need a higher target of cerebral edema, you need a higher target of sodium, but otherwise keep up your electrolytes at optimum level. Patient is euglycemic, prevent hypoglycemia and prevent extreme hypothermia and hyperthermia, special temperature more than 37.7 Celsius, right? And top of that, ventilation wise, neuroprotective ventilations, you should target carbon dioxide initial period with low side, hypocarbic, right? So I would target 35 mercury millimeters of PaCO2, target the pH of 7.35, 7.45 range pH, right? That is because when these things are changing, auto-regulation in the brain is going to change. That's why you need to maintain the potassiums as well. That's what you need to do. That's what neuroprotective ventilation, right? And make sure the temperature, so active management of temperature. So how long are you going to do this? 72 hours. After 72 hours, you need to come to realistic goals, neuroprognostication. If the patient is not coming back, you need to look for neuroprognostication after 72 hours. 3 days, maximum effort, doing the things. Okay, then you need to find what's going on in the brain. Are we doing the correct thing? So now we have fixed the primary problem. We are keeping maximum optimum state for this patient. Is it worth to keep this patient like Jackson and 30 for so long? So we need to come to realistic goals. I'm not putting blame to anyone because I have done that mistake in my life. Believe me, I have done. The people who work with me at Mathur, they know I was pushing, especially Subhani, Dr. Subhani Akka knows how I was doing with patients. But now looking back, I would say I would have not done that. Right? because I feel like, because when the people are coming and worshiping you, oh my God, you are the savior of my mother, I felt a bit of an ego saying, oh my God, I'm doing something better. Oh my God, but realistically, now I'm at a maturity saying, oh my God, whatever I did back days is wrong. So I wasted a lot of money, a lot of effort that can be utilized for other good patients. Because if you talk about the intensive care beds, how many beds do you have in this hospital? Is it easy to put a patient to intensive care? No. So you need to do that. Like, it's a very cost-effective way of management. You need to do that bit as well, right? So how we are going to do neuroprognostication? First, make sure you restore maximum normal physiology as much as possible. Give a sedation hold, and then you can look for the neurological assessment, and especially target the motor response. In GCS, you have the motor response. Look at this motor response. Then look for the reflexes, pupillary and corneal reflexes, and look for the seizures also, because these are the poor prognostic signs. And investigations wise, you can do CT brain. If you want, you can do an MRI in extreme cases to support your evidences. And you can do EEG, right? Then you can do somatosensory evok potentials. There are entity called the tissue markers. We can do blood markers for tissue damage, right? So, I think even in UK they won't do that. Inolase levels, they won't check that, but it can be done. So, what are the poor prognostic indicators? Absence of ocular reflexes. Pupil and corneal blink, if it is not there, it's one of the poor prognostic indicator. Then look for the seizure activities, any kind of fitting going on, right? So it's not good. And if there's a abnormal or poor motor response after adequate sedation hold, it's an issue. Then you can do a CT. If there's a hypoxic brain injury features, again poor prognosis features, right? And you can do a EEG. EEG, there's what we call burst suppression. If there's a presence of burst suppression, it's not good at all. If there's any new ongoing seizure activity, it's not good. The somatosensory evok potentials are much better. So those I don't want to tell about this end-to-end tests and stuff, because we are not in this country, we are not up to that level. But if someone asks what is the best poor prognostic indicator, that is the somatosensory evok potential, because it is not affected by your sedations, your paralytic agents, nothing. It won't help you, it won't affect by that, whatever the drugs we are giving to patient. And top of that, you can do even within 24 hours. You can quickly take your decisions, right? Then you can do your blood markers as well, right? So if the patient is having poor prognostic features, then you should think of withdrawal of care. After 4 days, are we going to take this patient? No, we need to take him out of the ventilator. Sometimes patients are having a brain death. So if the patient is not having a spontaneous breathing, look for the brain stem death, right? So if it is positive, then you can talk to family. You can convince, talking to family should be every day, remember. So daily give a small bit. They won't tolerate. At very, oh my God, that is the truth, right? Okay, today's like that, we will see, but I don't think he's going to do well. 80% he's going to die, but 20% we are giving our chance. Because next day they are coming to, they know that something going very badly, so they are conditioned themselves. Next day, give a small bit. After 3 or 4 days, you can say we have done CT, we have done EEG, and everything we have done. So, but I don't think his brain is, even the heart is working, his brain is not working that much. So we need to take a decision. What do you think? What we are doing is making him more like he's not himself. He's on a ventilator. We are iatrogenical doing. We are torturing him. Do you want me to torture your father? They will come to the idea at one point now, take it out. You need to take the tube out. Right? Before you take the tube out, remember about organ donation. Always harvest organs. Make sure if the patient having a good organ, so take them out because you can save another life as well. You can talk to the organ donation. If you may not know about this patient is fitting for organ donation criteria, it's a separate lecture, right? I'm not going to talk about organ donation. So you can talk to, in Colombo, we have the organ donation center as well, so you can bring them, ask, hey, got this kind of patient, do you think he's a good candidate at least to take the eyes? Come on, right? Give it a try. If you can ask, then you could talk to family, yes, there's a possibility he can do some merits, even he is dying. So having a good communication is much important. So try to take the organs if possible. You can save another life as well. Right? Okay, case 2. The 72 years old male presented to emergency department. Again, paramedics brought him after he was suddenly collapsed when he was walking in on his garden. Right? So the daughter was by the side, started CPR. Downtime was 12 minutes. This guy was an Indian Punjab guy. It's an asystole VTVF. ROSC came to the ED, and there was an extensive enterolateral MI. I did the echo bedside. Ejection fraction is 20%. Regional wall motion abnormality. So there's apical akindic segment, and NV is dilated as well. But the RA functions seem to be normal. So paramedics already intubated this guy. Patient came with metronidazole infusion as well. But his oxygen requirements very high. FiO2 70%, saturation is 93, PaO2 is a bit low side, and he was paralyzed and ventilating, and he's on metronidazole infusions. Maintain blood pressure very low. I was called by the emergency medicine physician asking for an intensive care bed. So what do you think? If you are the registrar, senior registrar, or a medical officer, are you going to take this patient to intensive care? Can you raise your hands? Who is going to take the patient to intensive care? This patient is already intubated, right? Give it the ventilation. No one. Okay. So rather than taking the decision, I would like to go a little bit deep on his medical background. So when I see the PICS means that we have an online system. We can see all the patient details. What you can do is here, you can take the call history from your the patient's relatives. When you go through the patient's details, I found patient is having a severe degree of Parkinson's disease. He's walking, but the thing is, we need a lot of support. He's severely demented and bad COPD. He was smoked for nearly 40, 50 years, like long duration. He had a ischemic heart disease 2020. There was 2 stents inside. So functional levels, we assess the functional capacity. We ask whether the patient can walk by himself. Does he need support or any aid? Can he climb upstairs? Can he do his own shopping? If he can do own shopping, it's a good thing, right? Own shopping. So he can't do own shopping. Can he go to walk around the garden? No, he can't. So this patient is still at the emergency department. He can climb up stairs, but he needs support and rails to take him upstairs. Right? So by looking at this, multiple comorbidities with a poor and so frail gentleman and coming with a poor functional state and now intubated and ventilated. So do you think if this patient come to intensive care, if we give positive pressure ventilation for 5, 6 days, will he going to be able? Are we going to extubate this patient at one point in his course? No, right? You can understand because whatever if you put a positive pressure with this kind of a COPD, because his oxygen requirement, because he seemed to be aspirated as well. That's why if you go to the examination findings, I found there's crepitation on the right side and reduced the air entry, and we did a CTPA, and there was a consolidation in the right side, already aspirated, very tight lungs. You need to give more positive, and there are bullae as well. So if I'm going to escalate on this patient, I don't think I can do anything. Like he is not for an intubation at all. I won't intubate this patient if this patient present to me. But anyway, he was intubated. Why? So someone has intubated this patient without knowing he's doing correct thing, right? So are you going to continue the same error that someone has done? For example, enthusiastic physician may be intubate this patient, right? And calling the anesthetist for an intensive care bed. So you know by your heart this patient is no, because totally different, because you are working in your intensive care so long, you know by your experience this patient is not going home at all. He won't tolerate positive pressure ventilation at any point. And on top of that, his kidney is going to shut down by the time we can't start CRRT. Definitely he will be on the ventilator for a couple of days and he's going to die. Right? Even he come out of this critical period, do you think he will have a quality of life? No, right? So what I did is, so first thing I question myself, is this patient is appropriate for level 3 care? Level 3 care means intensive care? No. Then I thought, okay, I will remove the tube and at least try to put a CPAP and help him level 2 or level 3 care. By looking that number, because he is have very drowsy, low, the conscious level is also very poor, and he may not tolerate the CPAP as well. And he already aspirated putting a CPAP, because sometimes physicians they call me and asking, can you give CPAP for this gentleman? Yes, they all the time call us and ask, why don't you give NIV for this gentleman? So no, I can't do that, because giving NIV, we are wasting our resources for this gentleman. Nothing will happen. The next question comes is, are you asking me to let this patient die on the bed? Yes, yes, of course, yes. Let's do that. But it's not that hard. You need to do it in a very nice way, because everyone is going to die. Offer him a good death. I think Vajra can understand the good death principle in behavior sciences they taught us. So there's an entity called good death. Offer them a good death, because we are dying human beings, right? We are made to die. We are Buddhist, but we never accept that. So then you need to come to a limit. So in UK, we have one thing called respect form. Respect stands for recommended summary plan for emergency care and treatment. Rather than even a nursing officer, rather than going towards the patient, they first ask, what is the respect form? If the respect form say, not for intubation, not for ventilation, they don't do anything. Right? Not for an antibiotics, they won't give even antibiotics. There are patients like that. So those are pre-discussions. You need to do that. But again, at this point, I put the respect form for this gentleman. Putting the respect form is a medical decision. As a doctor, it's a doctor's decision. Even a junior doctors, FY212, they take the decision. They can put the respect form, right? DNA CPR again is a medical decision. You don't have to ask from the relatives. Are we going to? Is it okay if we do not resist this statement? No, you don't have to ask. It's a medical decision, but it's your courtesy to let the relatives know. If the patient is having capacity means patient is conscious, rational, and if you can communicate with the patient, it's your duty to let the patient know. You talk to patient. I have done it, right? One patient who got a pancreatic say, and they put a stent. It's biliary leak. Patient is very nice. He's a golf player, right? Well-known golf player. He came, and tummy is like that. So patient is a bit septic as well. They want the intensive care, full escalation. I told him, and I told he's very bit, he's I think 60, he's young, 68, 60, 65 around. So I asked him, sir, do you want me to torture you? He said, no, don't torture me. I don't want tubes, so don't put me to ventilators, but I like something like to put nose something. I said, yes, of course, why don't I can give that, yeah, of course. All right. Okay. Be very frank with you. I don't want to, I'm not going to tell the name. One of the doctor's mother, by myself, keeping her live, having an end-stage lung cancer with all the metastases. I kept her alive for nearly 1 or 2 months in intensive care by myself, because she's a mother of doctor. That is the only reason for me to keep her alive, because he requested me. I said, yes, I can do that. Yes, of course I did it. What am I going to gain? This patient is going to die at one point. I wasted all them. And remember, we are blocking one ITU bed, intensive care bed. I mean, I wasted a whole lot of money for one patient, right? I'm so selfish. So, as a nation, if we want to develop, so we need to come to realistic goals. We can do favors, of course. I'm a guy who loves to do favors, but thing is, it has to be a realistic favors, right? So even when I was doing the COVID ITU at Kamarugama, so I was keeping a lot of patients alive. I knew the patients not going home, but still doing the percutaneous tracheostomies, showing colors. So I don't think I would have done it. At this moment, I would offer them a very good. I tortured them. Put in the percutaneous tracheostomies, subclavian lines, started CRRT, very nice, very high-fi stuff. Machines are running, right? But after that, COVID was a trauma period. So I managed. Initially, we started with 100% mortality, but we end up with the 15% mortality in my ITU. So the staff worked very hard. I pushed them up to the edge. So I would have done it very differently, more matured way. Because most of the time, physicians, they take in the patients. Okay, take this patient, put the ventilator, like that. They were requesting. So I was helping them because I'm junior. So at that point, I didn't know how to communicate myself. I didn't know how to say no. If I say no, it will be a very hard way. Like people are going to get annoyed with me. So anyway, that's how it worked. But I did mistakes in my life. I'm not ashamed to accept my mistake. Now I'm not doing it because I understood. I need to change myself. Right? So then other thing is you need to communicate it to the patients very nicely. So you use this spike protocol. Again, behavior sciences, Vajra. We were laughing when this behavior sciences thing they were teaching us. So again, I'm one of the guy who criticizes very badly, and I'm today telling it to my juniors about spike methods. So use this one spike method. It's for setting. Take the patient to a very comfortable room, right? Then rather than you jump into the patient, allow the patient to talk, emotionally ventilate them, so they will tell a lot of stories, listen to them, but don't take too much time like crying with the patient. So all the time keep your lead, right? You are the leader, so you take the conversation the direction that you want, you accept things, but come try to negotiate with the patient, relatives. If you can't negotiate, if they are so adamant, because I'm not a racist, because sometimes especially our Muslim friends, they are religiously, they loved, and they want to do everything in perfect way. We want this, they were asking, right? So it's very difficult because they have some like religious beliefs as well. So you need to respect that bit as well. You can't say, okay, no, it's not like that. Okay, you can understand, okay, yeah, because, but somehow try to understand them in a nice way. This is what's going on. This is the reality. You need to face this reality at one moment. Because one family once pushed me, 95 years old mother, right? One of the black lady. So they pushed me up to a level, asking them to do even a heart transplant. Right? Family. They believe that they can, it's UK, right? You can do anything in UK. They think like that. So they were asking me the cardiac, why you are not doing a heart transplant for this lady? So they won't accept it. So they it's very difficult. Like not like here people very nicely accept what you are saying, but they are not like that. They will kick you, they will jump out of the bed and like that. So Yeah, basically like servants. They don't care you are a doctor or not. You serve the people, that's it. Right? There's nothing different. So then other thing is invitation. So then you allow them to, they will come at one point, okay, saying, okay, I think what we're doing is not going to work at that point. That certain words they will speak. That bit you catch the word, you listen what they are saying, catch that bit, build on that one, negotiate that one. So it's a bit of art. And knowledge, you need to explain the way that they can understand. Don't use this hi-fi medical stuff. Just use something like we are putting a tube or thing. This retrograde, I can't ERCP or something. You don't use these big terms. Just say we are going to put a small tube to the bile tube. So that's it. What we are doing. Like they come with a very simple term, they can understand there is a growth there because of that it blocked it. So like that, very simply explain to them. Sometimes they will understand it. Then emotion wise, okay, you can respect their feelings. You can empathize, don't sympathize, don't cry with them. Don't tell your experience. Yes, my mother also had the same thing. Who cares that your mother had a problem? Who cares? It's your mother, but this is my mother. They can come and tell like that, right? So don't try to do that. Don't try to put the patient in yourself and talk. Then finally you summarize, and because during that session you are speaking a lot, you summarize it and tell, okay, this is the plan, what we are going to do with for your gentleman, your patient. Okay. So finally, third case, again from the emergency department, 55 years old female, known patient with COPD, presented to emergency department with shortness of breath, fever, managed as infective exacerbation of COPD. In spite of whatever the management they have done, patient was drowsy, poorly responding, require NRBM of 15 liters, and patient is bit high, is hypoxic, acidotic. There's a type 2 failure, right, and septic as well. So you are asked to review this patient. Are you going to take this patient to intensive care? I think it's unfair for not to speak now because I spoke nearly 1 hour. Give me a one single word, yes or no. Are you going to take this patient to ITU? Who say yes? Who say no? Yes. You can stand for what you want. Who say no? I need extra details rather than jumping and giving them giving what they want, what the emergency medicine doctors want. Because because of this patient, we are blocking a bed at emergency department. They have extra work. They need to push this patient to somewhere, right? So the best place is the intensive care, and all the parameters, all the things are fitting for an intensive care patient. Why can't you say? Why can't you take this patient to intensive care? Right? But the problem is, actually, if I go through this patient's history, she was a heroin addicted patient, severely cachectic, and having a very bad COPD, multiple hospital admissions, using home oxygen as well. On-air saturation usually is 86, but they are giving how much they are giving 50 liters and putting the saturation 90%. Oh my God, it's good actually. Bicarb is very high as well, right? And patient has taken methadone, and top of that heroin as well. And patient can't walk even at 10 feet. She can't climb upstairs. She got 2 carers at home, morning and she can't even go to washroom by herself. Poor functional status. Are you going to? What are you going to do? Are you going to intubate this patient at one point, if needed even? No. No level 3 care. Are you going to put CRRT for this patient? Dodgy. Yeah, totally agree. Dodgy. We don't know. Right? But again, intensive care CRRT. But I will do hemodialysis. If the blood pressure is stable, I will give her a chance by doing hemodialysis. I won't do a CRRT. Then NIV, I'm going to put BiPAP, CPAP. I will consider putting BiPAP, but I may not put an NIV, non-invasive ventilation, right? And top of that, you know, my decision was like, you can use the respirator is 10. Then I look at the pupils are pinpoint. I give naloxone. Patient walk out, say, go man away, right? And she kicked me out as well, right? Opioid overdose. That's it. So I said, come on, no need of intensive care. So you can manage the patient in the emergency department, then I came out. Right? Because when I see this patient, the carbon dioxide is retaining and respiratory rate is 10, right? Usually COPD, infective extubation, they won't have a respiratory rate of 10. I thought something is wrong. Then I went through the history. Then I found patient is on these drugs. She was given methadone freely. So she has taken methadone a lot. When you give the naloxone, she woke up like, oh my God, she woke up. She's a big Negro lady. Like very big, but she's very charismatic, very big, tall, what I'm saying. Right? That's it. Right? I want you to see this video if possible. I don't know, it's not working. It's about this respect form, how we do things. So no, it's not working. Okay, that's it. Any questions? Is it worth to have this kind of discussion? I didn't talk about anything apart from my experience. Everything I told you about my experience as a junior doctor, how I worked. Even I was a acting consultant, how I worked, and I reflect myself, and I told you in front of everyone, I did something wrong at one point, right? And I'm willing to change my approach towards the patient, right? Let's go reflective practice. That's where we are heading. Right. So reflect yourself, grab the knowledge, put it into yourself, then because the things will automatically come to you. You don't have to go behind things. If you do things in this way, if you are more analytical, more reflective, automatically you will bloom. So don't worry about it. It doesn't matter who you are. Okay. And any questions? Vajra, don't ask questions. Okay, and it's a pleasure to talk to you. And thank you. I want to say thank you to you, Jiva. You always put me into trouble, as usual. So again, thank you guys for listening this boring lecture for 1 hour. All right. Try to keep your heads up, especially during this lunchtime. And I wish best for you guys. And anytime, if I have time, especially, I'm willing to help Jiva because I know he has a vision. So we had a lot of chats about how to do that. So whenever, as a friend, long-lasting friend. So if you need help, I'm there. Okay. Good luck, you guys. See you.
Thank you very much, Chamindu. Of course, for a person who is coming from abroad for a vacation, it is very difficult to devote time. When he's on leave, it is very less time available. That is common to everyone, especially from my wife. She also came and just went back. She didn't have a lot of work here, but she had a lot of commitments, and then she had to attend to them. And the same issue apply to Chamindu also, but still, on my request, he came. So I thank you very much, and well, I'm really obliged that your commitment towards the development of this hospital was great. And whatever you did we are getting the results. So the team you trained have come here training our doctors. And that is one of the best things that should happen to any hospital. Now, Chamindu's group is a group unique. You don't find such groups in other hospitals. I have been working in so many hospitals, but I never found something like this. So that is what we expect from our consultants. Everyone should train their colleagues. Now that is one of the key things which is expected from a professional. Now, if you go to the definition of professionals, you will find one point as training their colleagues. So we are doing it, and we are doing it with a good heart, not because for the sake of training. So we are doing trainings for the sake of trainings. That is happening in the Ministry of Health. We have a lot of trainings, spend a lot of money, but still we are just having a training, which is not necessary sometimes, which is not expected by the people who are attending. But still, this is the training we need. You know, we have an issue of medical consultants. Most of the consultants have left the country. Still, we have our people here teaching us and helping us. So get that knowledge. Always keep in touch with him. I think it is possible. And he's a good friend of mine. Whenever he spoke to me on the first day, I got to know he will do a lot. So we continued our good work, and we trained a lot of doctors, nurses, even minor staff on the fields, the relevant fields. So we could do that and get this opportunity to think of training others. He teaches you, and you get your training and try to teach others. And that is being expected by us. So I'm opening an opportunity to the other consultants too. So I will tell them to follow this pathway where Chamindu did great work. So I thank you again, and I wish you all the best in your future career. And I wish, if I can, because I'm going to be here for some time, when he comes back after his work there, to be with me in ability. Thank you very much.